Original, mature, still looking good and easy to use, and still having an impact.
I can feel totally confident when I prescribe Gonalev because I'm sure that I'm making the best choice and this is the best gift that I can give to my patients.
By a potency, consistency, and safety.
And has transformed in many ways the way in which we carry out ovarian stimulation. It was the original recombinant FSH, and it emerged around about the same time as the antagonist. And together these two compounds have altered the efficacy and the safety of IVF in a very profound way.
I feel safe and I feel I'm doing the best to control the ovarian stimulation on my ART patients.
In my daily practice with Gonalev, I'm sure that I will maximize the oocyte health with a reduced amount of drug used and with a better compliance for my patients.
It is safety, consistency, reliability, and success.
I will never forget 25 years ago when I visited Serono Laboratories in Boston and was introduced into the procedure of producing recombinant Gonalev and became the gold standard in my center, nowadays also in addition with recombinant LH.
When we started this journey, we could have never imagined it would take us to where we are today. Looking back, it was during a time of pioneering advancements in biotechnology that Gonalev was born. It was possible thanks to a deep love for science and a lot of determination. Innovation has always been an integral part of our patient-centric journey, striving to contribute towards an optimal treatment experience. And so, Gonalev has changed and grown over time, responding to your needs and your patients' feedback. Over 4 million babies have been born worldwide, thanks to your efforts and the helping hand of Gonalev. It's been an incredible journey so far, and yet all this is only the beginning.
It says a lot that this product is still going strong 25 years later.
Thank you and congratulations for your 25 years of life. Let's go together for 25 more.
We have an exciting road ahead of us, so let's raise a toast to realizing millions of dreams yesterday, today, and tomorrow.
So I go. Okay.
One, two, three. We got not 5, 10.
Hello, everyone. Welcome to the Lebanese Fertility Society webinar. I'm happy to see you again. It's our first webinar in 2022, and you are more than 290 attendees tonight. So it's a real success. We'll talk about new updates in infertility. We'll try tonight answer to many questions in controversial topics in infertility. First, we will talk about the dogma of freezing embryos. What are the inconvenients and advantages of freezing embryos? Freeze all, the latest update. Another important hot topic to improve success rate in ART is the implantation process. What can improve endometrial receptivity? How we can optimize implantation rate? And what are the best indicators for the state of the endometrium? Finally, what are the best protocols to prepare the endometrium for frozen embryo transfer? What are our options and what are the advantages of each one of them? How we can control the endometrial preparation and what elements we should monitor to optimize the synchronization between the embryo and the endometrium. All these talks will be moderated by our exceptional moderators, Dr. Layal Abi Zeid and Dr. Toufic Naba. Dr. Abi Zeid, she's a gynecologist, sexologist, reproductive medicine, and biology of reproduction. She's in St. Joseph Fertility Center and in Clemenceau Medical Center. Dr. Toufic Naba, he's a clinical director of German Lebanese Medical Center, and he's the General Secretary of the Lebanese Fertility Society. Please, Dr. Abu Zeid, the floor is yours to present our eminent speakers.
Thank you, George. Thank you, everyone. Thank you for your presence after in 2022. We will start our webinar with Professor Antoine Hannoun, who is a professor in the American University of Beirut Medical Center. He is the founder and the present director of the IVF Center. He is specialist in reproductive endocrinology and infertility. His talk is about freeze all, yes or no. Please, Dr. Hannoun, the floor is yours.
Can I share, if you are hearing me, my
We are hearing you.
Okay, my talk today is about freeze all, yes or no. After an introduction, we'll talk about the freeze and all indications and then pregnancy outcome after frozen embryo transfers. What's the definition of freeze all? I don't know about the picture. Where is the... Okay, I don't know whether you are seeing me or you are not seeing me. Anyway, I will talk. By definition, freeze all when we don't transfer in a cycle any fresh embryos. We freeze all the embryos. Definitely we have indications. The main indications are two. If we are looking for patient safety in any procedure, and we want also to increase the pregnancy success rate. Now, for patient safety, we are dealing with the ovarian hyperstimulation syndrome and how to avoid this syndrome. For the pregnancy success rate, we have two factors. The lab quality, which will produce the embryos, and definitely if we have good quality embryos, we will have a better success rate. And the endometrial receptivity, if we have the best embryos and we implant them in a non-receptive endometrium, also the success rate will be affected. We have three main groups for freeze-all indications: the pre-planned, the rescue cycles, and still the controversial indications. Starting with the pre-planned, sorry, I'm just arranging for some on my slide. Starting with the pre-planned cases, we are talking about patients with polycystic ovary syndrome or previous history of ovarian hyperstimulation, and patients undergoing pre-implantation genetic testing. For the first group, it was found that the best way to avoid ovarian hyperstimulation and to maximize the patient's safety is to prevent its occurrence. We have two types of ovarian hyperstimulation: the early ovarian hyperstimulation occurring 3 to 7 days after triggering by HCG, and the late onset about 12 days after embryo transfer with positive pregnancy. For the first indication to prevent ovarian hyperstimulation, ovulation triggered by GnRH agonist instead of HCG to avoid early ovarian hyperstimulation was first reported by Devroy in 2011, but is now a well-established clinical practice. Now, freeze-all was added to the agonist trigger cycle for two reasons. The first one was they found that if you transfer fresh embryos, the success rate is low. And the second reason is that if we have a pregnancy, we will have the late onset ovarian hyperstimulation features. Now, some centers or some physicians are transferring fresh embryos when we give the trigger, but they have to individualize the cases and they have to support the endometrial or the luteal phase by both estrogen and progesterone. But this is definitely not recommended in many countries around the world, especially European countries and in the States. When we trigger with the agonist, we have to freeze all embryos. Now, patients undergoing pre-implantation genetic testing, these include pre-implantation genetic testing for aneuploidy, PGTA, for monogenic defects and for chromosomal structural abnormalities, and pre-implantation genetic screening in selected IVF cycles when we want to make sure that all the embryos being transferred are euploid or normal embryos. Now, in the past, when we used to have pre-implantation genetic diagnosis, we used to have biopsies, embryonal biopsies at day 3. But what are the advantages and disadvantages? Now, day 3 embryo biopsy, all randomized controlled trials showed no increase, even a decrease in the pregnancy rate compared to embryos transferred without a biopsy. In day 5, when we do the trophectoderm biopsy, it has less injury to the embryo, and in this case, we can have two options: either to freeze all blastocysts at day 5 or to transfer embryos at day 6. And most studies showed that embryo transfer at day 6 is less successful if compared to freezing all blastocysts and transferring them in later cycles. Now, the majority of physicians will choose freeze all options to transfer the after taking biopsies from blastocysts. This is for the pre-planned cases of freeze-all. What about rescue cases? If we are stimulating a case and we see that, especially we have to use the antagonist protocol, and we can detect that that patient will hyperstimulate if we trigger with the SCG, we can shift to triggering with the agonist and freezing all embryos. In the second category, if we have uterotubal factors or if we have slow-growing blastocysts. For avoiding the ovarian hyperstimulation, I said we trigger with the agonist and we freeze all. Now, for uterotubal factors discovered during stimulation, it might include polyps, submucous fibroids, endometritis, hydrosalpinx, thin endometrial lining. But definitely, many of us will say that most of these abnormalities should have been detected before starting a stimulation cycle or an IVF cycle. So this is recommended. Now, cervical stenosis is an entity when we have really difficult embryo transfer. So we try to transfer, and that transfer will be very traumatic, and one would elect to freeze all and correct the stenosis or the abnormality in the cervical canal and transfer later. What about the endometrial thickness? Now we know that an endometrial thickness, very thin, which is less than 6 millimeter, the success rate will be low. We say that it's acceptable if we have 8 and more, and between 6 and 8, 7 is a gray zone. So suppose we are stimulating a patient and we discover that the endometrial lining is still thin, so one can elect to transfer to freeze all and check the problem in the endometrial lining and transfer later. Now for the endometrial thickness, this is a study from Canada in 2018. The impact of a thin endometrial lining on fresh and frozen thaw IVF outcomes. This is a retrospective study and analysis of over 40,000 embryo transfers where they have recorded the endometrial lining thickness. The conclusion, they found that clinical pregnancy and live birth rates decreased and the pregnancy loss rates or abortions increased significantly with each millimeter decline in the endometrial thickness below 8 in fresh cycles and below 7 in frozen cycles. What about the slow-growing blastocysts? Sometimes we have like grade A embryos, but we found that there is a delay in the growth of those embryos. And we reach blastocysts, and these are still very early blastocysts. We might wait for those blastocysts till day 6, and we find that they really grow to a better condition. So in such cases, many would freeze those embryos and transfer them in later cycles. Now, if you transfer, as I told you, in day 6, we have lower pregnancy rate for such delayed embryos. And we might have 2 reasons for the lower pregnancy rate. It is either it is an intrinsic defect in those embryos, and this is why we have the delay in the growth, or because we have asynchrony between the endometrial lining and the delayed embryo or the slow-growing embryo. Now we come to the controversial indications, and we have inadequate serum progesterone levels, endometriosis and adenomyosis, repeated IVF failures, risk of thromboembolic diseases. Now starting with inadequate progesterone level, and inadequate in the sense of that at the day of trigger we have elevation in the progesterone level, and that elevation was found in some studies, in the early studies, that it will decrease the pregnancy rate. But up till now, it's really still we do not have an agreement on this topic, because many studies we do not have like standardized studies. What is the level of progesterone that we have to take, above which we say that we have to stop or freeze all and not transfer embryos? Because the studies, we have many variant studies, whether 0.8, whether 1.14, 1.2, 1.8, 2, we have all studies quoting these levels. So we don't know. And what about the duration of progesterone increase? Is it the duration of the increase, or is it the quantitative value above a certain cutoff? What about the effect of low progesterone level? So, and what is the cost effectiveness of freezing all embryos because of the progesterone level? This is why it is not really fully agreed that above a certain level of progesterone, you have to abort or you have to freeze all and transfer in later cycles. Endometriosis and adenomyosis, there are recent observations only that might show a potential benefit of freeze-all strategy, but the proposed hypothesis is the endometrial receptivity, and we do not have RCTs for that conclusion, so it is still also controversial. What about repeated IVF failures? Many physicians, when we know that this is a frustrating issue for the patients and for the treating physicians, and when we have no obvious cause after requesting all the studies that we know that might affect the failure, might lead to the failure of the cycle, then many said, let's try to freeze all. We have some studies that showed improvement, but we do not have really, we have conflicting results where other studies did not show any benefit. So this topic up till now is still controversial, whether to freeze all in repeated implantation failures. What about the risk of thromboembolic disease? We know that the pregnancy per se with a high estrogen level, it is a high risk for thromboembolism or thromboembolic diseases. In IVF pregnancy, we know that we have higher estrogen level from the stimulation, and hence we are increasing the risk of TE. Now, studies confirm this increase in thromboembolic diseases with fresh cycles. Compared in the pregnancies, compared to normal pregnancies, not IVF pregnancies. Now, frozen cycles, the risk of thromboembolic disease equals the natural pregnancy risk. So the conclusion of this is that a freeze-all strategy can be applied in IVF cycles in women at high risk of thromboembolic disease to decrease if a pregnancy occurred with the fresh embryos, to decrease the risk of thromboembolic diseases, but definitely not in all cases without a high risk of thromboembolic diseases. Now we come to the point that freeze all for all. Did we reach to that? Now, when freeze all for all, this means we have to compare the success rate of fresh frozen embryos to the success rate of frozen embryo transfers. Now, why would one think about freeze all for all? Because previous studies showed that exaggerated response to stimulation will have histological changes in the endometrium, will decrease the success rate. Elevated levels of progesterone, as we mentioned before, also might decrease the pregnancy rate. Now, stimulation also might lead to alteration in endometrium gene expression compared to normal pregnancies. Superovulation alters the immune environment of the endometrium, and high levels of hormones might lead to epigenetic changes on the embryo, which lead to abnormalities in the embryos or decrease in the implantation rate. Now, for these reasons, some are advocating that let us freeze all for all patients to avoid the disadvantages of the fresh embryos in a stimulated cycle. Now, what is the literature and the most up-to-date literature about the freeze all for all? Now, some early studies, few studies, suggested an improved pregnancy outcome when compared the frozen embryo transfer to fresh embryo transfer. Now, Akaria et al. In 2018 from USA, they reviewed in a retrospective study, reviewed 80,000 cycles. They compared the first frozen embryo transfer with the first fresh embryo transfers in patients. And they discovered the conclusion. They divided the patients, this is a retrospective study, they divided the patients into three groups. High responders, when the antral follicle count is more or equal to 15, intermediate responders 6 to 14, and low responders 1 to 5. And they found that we have higher pregnancy live birth rate in a frozen embryo transfer, 52 compared to 49, the fresh. So we have an advantage in high responders. And 52 and 49 are near numbers, but because of the high number of cycles, 80,000, we have statistical significant difference here. The intermediate responder and the low responders, on the contrary, they found a lower live birth rate in these two groups compared to the fresh, 35 to 41 and 11.5 to 26. So the caution here is that what's happened? I'm sorry. Okay, further. So the caution here is that the reason for freeze in this retrospective study, the reason for freeze all was poorly documented. So we cannot really count on this. Please move this window away from the shared application. Or can we move it? I don't know. Anyway. Now, in 2019, Bosto et al. From Greece and Human Reproduction, they have a meta-analysis of more than 5,000 cycles in RCTs. And they compared also the first frozen embryo transfer to the first fresh embryo transfer. And the result, they have higher live birth rate in frozen embryo transfers, also only in high responders. But here we have many limitations. Heterogeneity in all aspects or in all steps of the cycles between the different RCTs concerning the stimulation, the trigger, luteal support, etc. And also that here the definition of a high responder was not well documented. Roque et al. From Brazil, 2019 also, in another meta-analysis, they found the same finding with the previous meta-analysis, that the only advantage in freezing all is in high responders. But the overall cumulative live birth rate was not different between the two groups. Other studies from China in 2018-2019, they compared elective single embryo transfer between frozen and fresh, and they compared both blasts and the cleavage state. In the blasts, the outcome in the frozen embryo transfer was better, but this was not found in the day 3 embryos. Okay, so the last conclusion from this study is that we might have advantage in high responders, and if one would think that in high responders who are susceptible or at increased risk for ovarian hyperstimulation, so many of us will go to freeze-all strategy. Whereas in other categories or in all population, the live birth was not static, was not different between frozen and fresh embryos. Okay, if we have to choose the frozen embryo strategy or freeze-all strategy, what is the effect of freezing on pregnancy and on children? Now, for miscarriages, no difference. For here we are comparing the offsprings or babies and even adults resulting from fresh embryo transfer compared to frozen embryo transfer. So the miscarriage rate, no difference. The preterm delivery, no difference in the risk of delivery before 37 weeks. Fetal growth, a higher risk of large for gestational age was found in freeze-all. The mechanism is unknown. Probable that frozen embryo transfer after artificial preparation of the endometrium, they discovered the large babies in this subgroup, whereas this was not found when you prepare the endometrium naturally. For gestational hypertension and preeclampsia, there was an increased risk of hypertensive disease in pregnancy in freeze-all cycles, and the mechanism is suggested to be due to artificial preparation of the endometrial lining. Other obstetric and perinatal outcomes, there was no difference in gestational diabetes mellitus and placenta previa, antepartum hemorrhage, congenital anomalies, and perinatal mortality. What about the effect on children? The long-term health outcome, similar health outcome at 3 years follow-up, and similar academic performances at 15 to 16 years of age. So really no harm on children except for the large for gestational age babies, which might increase the risk of cesareans, trauma during delivery, infections, etc. So what's the take-home message? Freeze all for all? Not yet. Thank you.
Thank you, Dr. Hannoun, for this wonderful presentation. We will move to the second presentation for tonight. It will be about endometrial receptivity, and Dr. Elie Snaifer will give the talk. He's an infertility specialist and the head of the IVF unit at St. George Hospital University Medical Center. Dr. Snaifer? Yes, the floor is yours.
I am very glad today to be with you to talk about a very complex talk about endometrial receptivity. I have no conflict of interest. The content of this subject today is to talk about the definition of endometrial receptivity and implantation failure. I will talk also about receptivity and the active role of the endometrial. I will talk about conventional and modern markers and the approach to improve the endometrial receptivity in recurrent implantation failure and take-home message. Despite its many advances and achievements in the field of reproductive medicine, we have long negligence toward endometrial factor. It's very, the definition of endometrial receptivity, it's a very broad definition. We defined it as the ability of the endometrium to provide embryo-friendly condition. You cannot really talk about endometrium receptivity without talking about window of implantation. So conventionally, it was believed that window of implantation was about 4 to 5 days in the middle luteal phase. But recent molecular studies, proposed to narrow this window and to be about 30 to 36 hours. Now the question is, do we think that the endometrial receptivity is important? Opinions have split on this question. We know that embryo account now for 1/3 of implantation failure, while suboptimal endometrium receptivity is responsible for the remaining 2/3 of causes. Based on this, I would say that the endometrial receptivity is important. But what about selectivity? We talk about receptivity, but we also ask always about selectivity. These are two complementary concepts that enable the endometrium to function as biosensor of embryo quality. And this concept is very important, the biosensor of the embryo quality of the endometrium. Pardon. Here in this figure is a summary figure describing the fate of an embryo based on its quality. So we can see the receptivity that would lead to a successful pregnancy with high quality haploid embryo. But if we have suboptimal receptivity, what is in the red, the suboptimal receptivity would lead to implantation failure in this context. On the contrary, if you see the selectivity, a poor quality should be denied implantation by endometrial selectivity. The good selectivity must refuse the implantation to preserve the maternal resources. But a suboptimal selectivity in the red would lead to early miscarriage of an haploid embryo. So these two concepts about receptivity and selectivity and the interaction about haploid and anhaploid, it's what we can talk about a biosensor of the endometrium. Now, the definition of recurrent implantation failure. Recurrent implantation failure is one of the main challenges in women reproduction. There is no universal established definition. We have numerous definitions because of this complexity and the redundancy of this recurrent implantation. So I will talk about the definition of ISHRI best practice guideline published in 2005. It's the failure of implantation after more than three or more embryo transfer with high quality embryo, or the transfer of more than 10 embryo in multiple transfer. The implantation failure as definition is the absence of gestational sac on ultrasound after more than 5 weeks post-embryo transfer. Here about recurrent implantation failure, we have many causes. We have a well-established causes like anatomical causes like fibroma, adhesion, hydrosalpinx, and we have the unexplained causes like immunologic, non-immunologic, chronic endometritis, thin endometrium, etc. Data on the right, if you see the pyramid, data on the right shows the fate of transferred embryo. We can see in the spontaneous or in IVF procedure that the vast majority of losses occur either pre-implantation or immediately post-implantation. That could just be due to failure of the embryo to develop but also it's possible that there is a role of the endometrium to determine whether or not this embryo is allowed to implant. And this is what we call before the biosensor of the endometrium. In this retrospective analysis of frozen haploid embryo transfer, we have the result that if we have haploid blastocyst and we transfer 3 embryo at least, we have less than 5% that would fail to achieve a clinical pregnancy. They made the proposal that REEF can be minimized by transferring haploid embryo. But who say that we have always haploid embryo? And who say that if we have a haploid embryo, it's really a haploid embryo? Because now the time is to change, and we are changing to focus from embryo to the endometrium. When the embryo is perfect, the endometrium may not be a significant factor, but most women with REEF do not have really a perfect embryo, or we don't know about the status of this embryo. So in these cases, the endometrium may become a determining factor. Okay, the presumption that an embryo has to be haploid to implant is being challenged, as we are seeing now, mosaicism embryo, leading to a healthy live birth. Now there is a problem about language. When we talk about endometrium, we talk about receptivity, but receptivity implies a passive role of endometrium. It's a passive role for implantation that allows the embryo to adhere before it breaches the epithelium and invades the stroma. But we have other passive role for the endometrium. We have also the active role of endometrium. That is also what we call before the biosensor. Now about the deciddualization. The process of deciddualization for implantation is very important because it permits to the endometrium to act as a biosensor and to enable it to determine whether implantation should be allowed to proceed or not. In this study done by Emma in 2020, we can see that during deciddualization, stromal cells became either decidual or senescent decidual cells. In the absence of immune cell clearance of senescent decidual cells, decidual cells become progesterone resistant. And this progesterone resistant will lead to failure of implantation and to recurrent pregnancy loss. This is a very important study done by Weimar about the active interaction between the epithelium and the embryo. If you look here about a normal fertile woman, when we put in the endometrium, no embryo, high quality embryo, and low quality embryo. In no embryo and good embryo, quality embryo, there is a migration of stromal cells toward this embryo. But what was striking in that is the presence of abnormal embryo, for example, 3PN embryo. And in this condition, the cells did not migrate towards this embryo. So there is something about this embryo that the cells recognize and decide to stay away from it, and we don't have implantation. Here we compare the normal fertile woman with the REEF, with unexplained recurrent miscarriage. The experiment was repeated using cells taken from women with history of unexplained recurrent miscarriage and observes that in this woman, when low quality embryo were placed, contrary to the normal woman, in contrast to the group C, if you see here, the cells migrate to this embryo. This showed some evidence that the biosensor element plays an important role in the implantation. So in this woman with RIF, this biosensor will not act very good. So we have a implantation for a abnormal embryo that lead after to a miscarriage. What do we want from a practical point of view? Ideally, we want a test to measure a marker that would tell us if endometrium is adequate or not. In simple terms, this will guide us to perform the embryo transfer with good chance to success or not. We have many markers. I have here a summary of this marker. We have the ultrasound marker, the thickness about cutoff around 7 millimeter, the endometrial volume, the cutoff more than 2 millimeter, the endometrial pattern, triple line, the endometrial blood flow, uterine, arcuate artery, blood flow, velocimetry, etc. And we have the uterine contraction, the hysteroscopy, and the endometrial biopsy. By far, ultrasound is the most popular test used to measure a variety of markers related to endometrial receptivity. It's quick, cheap, easy to measure, but the question is it useful? Several studies of Doppler showed no association between endometrial perfusion and clinical outcome, but there was a degree of association between subendometrial space perfusion and clinical pregnancy, mainly the vascularity index and flow index. So vascularization of the endometrium and subendometrium is important, but still there is no cutoff to guide us to perform the transfer or not. About the ERA test, complex molecular testing, about many 238 gene, etc. The aim was to identify the asynchrony between the time of embryo are ready to implant and the time when endometrium reached the highest receptivity. The ERA was the oldest and the oldest test, but now we have many other tests. A prospective control cohort study that compared clinical test result between a woman with repeat implantation failure and control show that we have a difference in clinical tests. The result was that in RIF patient, we have a lower vitamin D level, lower mean mid-luteal progesterone level, and we have more chronic endometritis in the group of RIF in several trials. Now the question, how to approach the endometrial receptivity in RIF? Does endometrial scratching promote implantation and live birth rate in patients with RIF? Although several studies showed at first that scratching is beneficial, very recently, a properly powered randomized trial study has been published by Lancet in 2019, and that found that no significant difference in ART outcome after scratching. So the question is, so to scratch or not to scratch? We don't know. Currently, we need more and more data to be to have a cutoff about scratching. Now, talking about contraction, we know that elevated estradiol level during the control ovarian hyperstimulation lead to increased expression of uterine oxytocin receptor. This increase of uterine oxytocin receptor increase prostaglandin F2 formation that affect the contraction and decrease the perfusion. So the question was, oxytocin antagonist that was used to be a tocolytic can affect endometrial perfusion and receptivity? In a clinical in vitro study, we, excuse me. So before, about perfusion, we know that atosiban and baruziban improved endometrial blood flow in animal model. Clinical study about 26 women receiving atosiban versus placebo prior to day 3 embryo transfer. We have receptivity index, combined endometrial thickening, volume flow, subendometrial flow, uterine artery resistant index, vessel architecture. Women who have taken atosiban presented with characteristic more predictive of implantation. And in clinical in vitro study, prolactin release as marker of decidualization in endometrial explant was checked in a sample exposed to high estradiol concentration. They found that high concentration of estradiol decreased the decidualization, and intrinsically, this effect was reversed by addition of atosiban. So the atosiban reverse the effect of high estradiol in hyperstimulation cycle that decrease the decidualization. Now we have other approach to improve endometrial receptivity. They are not in practice, like intrauterine administration of HCG. I will talk briefly about growth hormone, the effect of growth hormone on uterine receptivity in women with REEF in a oocyte donation program. The result was that significantly we have a significantly thicker endometrium, better reproductive outcome compared to untreated REEF patient or women receiving their first IVF cycle. About endometrial receptivity in REEF and chronic endometritis, we can know that we must treat effectively endometritis, chronic endometritis, with first-line treatment, oral doxycycline. We can add also metronidazole or ciprofloxacin. Now, take-home message. The endometrium is an active participant and biosensor in successful implantation. Specific endometrial markers are associated with REEF and can be used to guide management. Future studies are needed to test the concept of using an endometrial diagnostic toolkits in women with REEF versus a current approach with blindly applied add-on treatment. All the novel intervention aiming to treat unexplained REEF lack the evidence required in order to incorporate the standard of care. Properly designed randomized trials are therefore needed to clarify which could be beneficial in REEF treatment. Progress is inevitable, sooner or later, but the ultimate problem and concern will remain the economic problem. Thank you for your listening.
Thank you, Dr. Snaifer, for your excellent presentation. I think you're going to have a lot of questions at the end, and same for Professor Hannoun. We're going to continue with the third speaker. Our third presentation is going to be by Dr. Hady Hachem, who is a reproductive endocrinology and infertility specialist. He's the medical director of the IVF St. Joseph Fertility Center, and he's going to present frozen embryo transfer. What is the optimal preparation? The floor is yours, Dr. Hachem.
Thank you, Dr. Toufic. I'd like to thank our president, Dr. Abitayeh, and our eternal sponsors, Merck, for always helping us with these webinars. So I was asked to talk about the frozen embryo transfers protocols. As you know, today, frozen embryo transfers are integral to any IVF program. If you look at the numbers in the United States, in 2015, the number of frozen transfers surpassed that of fresh transfers. And as of last year's numbers, it accounts for 77% of all transfers. The trend is the same in Europe, albeit a bit later, with about 40% of transfers being frozen. Now, we don't have any national data in Lebanon, but I can give you our data at St. Joseph Fertility Center. In 2021, we performed more than 500 transfers. 54% of those were frozen transfers. Now, it is well known that the pregnancy rates, the ongoing pregnancy and the live birth rates are always as good, if not better, with the frozen cycles. Now, the question is today, what is the optimal protocol for frozen transfers? As you know, the most commonly used is the artificial cycle, the hormone replacement one, followed by the natural cycle, whether it's true or modified, and there's the mildly stimulated cycle. Now, there are lots of variations, really lots of variations in each and every one of these protocols. What to use, which estrogen, which progesterone, when to start the progesterone, should we use an agonist, when to stop them, etc. So I'm going to try to answer most of these questions in the coming 15 minutes. And I'm going to start with the most commonly used protocol, the artificial cycle. Now, in the artificial cycle, we use estradiol in order to prime the endometrium and to suppress any spontaneous follicular growth. Now, the first question is when to start estradiol. Should you start it on the first, the second, or the third day of the cycle? The answer is simple. It doesn't matter. Day 1, 2, or 3 is the same. Even in patients with short cycles, when one might feel that there might be an early follicular growth, it doesn't matter. No difference whatsoever. The second question is, what do you use, the fixed or the incremental protocol? Now, in the fixed protocol, the estradiol is started at the same dose from the beginning. Here I give the example of oral estradiol, 6 milligrams per day, started from the first day until after the pregnancy test. In the incremental protocol, the idea was to try and mimic the physiological cycle where the estrogen rises progressively. However, if you think about it, there's nothing physiological about an HRT cycle, all right? So in the incremental protocol, usually with the oral estradiol we use in Lebanon, it's 4 milligrams per day till day 6, increased to 6 milligrams starting on day 7. Now, these protocols have been compared across the years. The last study, the last relevant one from 5 years ago by Madera and colleagues in Spain, showed there was no difference whatsoever between the incremental and the fixed protocol. Now, patients usually prefer the fixed protocol because it's easier. You don't have to change doses or medication. What about the type of estradiol used? Now, there are many types. There are the oral ones, the micronized and the valerate. There's the patches, and there's the vaginal estradiol. Now, in Lebanon, we only have the oral available. And a recent survey from a couple of years ago from the IVF International Society showed that there's largely, this is what we use the most, the oral estradiol, followed by the transdermal and the vaginal. Now, the results are the same. There have been countless studies across the years, no difference in the outcomes when using this or this or this. What's different, however, is the patient experience and some cycle characteristics that could be important in some cases. Now, this is a study that we published a couple of years ago with my friend and colleague from France, Professor Bouet, where we compared the transdermal, the patches, to vaginal estrogen. Now, what we found was that the live birth rates were comparable. However, some cycle characteristics, such as the endometrial thickness, was higher with the transdermal estrogen. There was a shorter duration of treatment, and the patients were satisfied with transdermal better than they were with the vaginal because of the fewer side effects. All right. So I think whenever you're choosing your estradiol, you should take into consideration the patient satisfaction and some cycle characteristics that might require changing the route of administration. Another question for HRT cycles, the use of GnRH agonist in order to prevent the premature ovulation, which occurs in about 2 to 7% of the cases. Now, this is the often cited study that goes back to 2004, which initially showed that using a GnRH agonist before the cycle increases the live birth rate. However, since that study, there have been many studies, many RCTs, very good RCTs, recently coming from China that showed that there is really no use in using the agonist before the artificial cycle when talking about the live birth rates. Of course, using an agonist will decrease the rate of spontaneous ovulation and therefore the rate of cycle cancellation. But at the same time, the agonist has significant side effects. It costs a lot of money. So this should be taken into consideration whenever we decide on using it. But when it comes to the cycle outcomes, it does not have any advantage. Moving on to the progesterone, and this is where we have the most variability. First, what the route of progesterone administration? Of course, the intramuscular, this is the preferred way by the American school. We have the subcutaneous. the vaginal, which is the preferred route. In Europe, we have the oral and we have the rectal. And even in the vaginal, which we most commonly use in Lebanon, we have so many variations, so many medications to use. So which to choose? Now, the intramuscular have been the gold standard for long, and it has been often compared with the vaginal with different outcomes. This is a recent study which was really discussed quite often last year. This is an American study which was sponsored by Ferring, who produced the Endometrial. So this is a 3-armed non-inferiority RCT that compared vaginal to a combination of vaginal plus intramuscular every 3rd day to the intramuscular daily. Now, when they produced the interim analysis, they had shown that there was a 40% reduction in the live birth rate when they used the vaginal alone, and this arm was stopped. So they continued with these 2 arms, and they found that there was no difference in the outcomes when using intramuscular or vaginal with intramuscular every 3rd day. Now, the big loss of live birth here that was seen in the vaginal arm was mainly due to a very high miscarriage rate, which was about 50%, significantly higher than these 2 arms. So this study kind of showed that the vaginal, along with intramuscular, was comparable to the intramuscular. It is a very good study. It's not a perfect one. There are several things to criticize. One of them is that in the vaginal arm, the patients had half a day less of progesterone when compared to the intramuscular. Now, the authors say it didn't impact the outcome, but I still think that half a day in a frozen artificial cycle could have a significant impact. And of course, the subjects preferred the vaginal because of the fewer side effects compared to the daily IM injections. This is another study published last year. This is a study comparing vaginal plus oral progesterone, Dufaston, 10 milligrams BID, to vaginal progesterone. Now, this is not a randomized trial. It's a prospective study coming from Vietnam. And what they found was the live birth rates were almost the same, a bit higher by using the combination, but that was at the limit of significance. Now, the authors did a multivariate analysis that eventually showed that the outcomes were better using vaginal and oral progesterone, and that was mainly due to a significant decrease in the miscarriage rate. As you see, miscarriage rates were significantly low in both arms. Now, what they found something that was quite surprising, and that the birth rates were significantly lower when using the vaginal and the oral, but there wasn't any explanation to that. So this is a combination that seems to be quite efficient, and I can tell you from my practice and from many of my colleagues, it's something that we use quite often in Lebanon, especially with the recent spike in prices and the absence of certain medications. Now, a quick word about the Polytex, the subcutaneous progesterone. I don't think it has got the FDA approval in artificial cycles in the States, but it's quite often used in Europe, and there have been several studies that compared it with the vaginal, and it showed similar outcomes. Now, it is most commonly being used in combination treatments, as we're going to see in a bit. The second question regarding progesterone, when do you start the progesterone? All right, this is something that we often debate between colleagues. I found in the literature only 2 RCTs that looked at cleavage stage embryos and 2 RCTs that looked at blastocysts. And they all showed the same thing. There is no difference whatsoever. So if you transfer your cleavage stage embryo, you could transfer it on day 4 or on day 3 after progesterone. And the same goes for the blastocyst. It can be done on the 5th and it can be done on the 6th day. There is no difference whatsoever between these 2. Now, this is an interesting study I found when preparing this presentation, published last year, 2 years ago, actually, from Belgium, where they were comparing the transfer of blastocysts on the 6th versus the 7th day of progesterone administration. Now, the live birth rates were comparable between these 2. But in the subgroup analysis, they looked at the day 6 blastocyst, and what they found was that the miscarriage rate were cut by half when they transferred on the 7th day of progesterone. The live birth rates were increased, again, at the limit of significance. So what the study showed that maybe there might be a place for 1 more day of progesterone when transferring day 6 blastocysts. I'm not aware of any other studies that looked at that, but I think this is worth looking at in the future. Now, the most important recent variation when it comes to progesterone is the endocrine monitoring. You know, for long, all patients received the same progesterone, the same level of progesterone. It was a standard the standard of care was just the same dose for everyone. But recent studies have shown that there's quite a significant marked variability between patients, the serum progesterone levels, that obviously impacted the reproductive outcomes. And this is why we've been seeing lots of studies recently looking at the threshold of progesterone before transferring your frozen embryos. We've seen a lot of those coming from oocyte donation program, but also from frozen embryo transfer programs. Now, the threshold that we often see is around 10 nanograms per ml. This is the meta-analysis published last year in Fertility Society that kind of looked at all these studies. The problem with these studies is they're quite heterogeneous because you have different kinds of progesterone used. We have different measurements. Some measure on the day before, some measure on 2 days before, some measure on the same day. So it's very difficult to come out with one number. But this meta-analysis, what they did is that they grouped them according to the threshold that the authors used. As you can see, you have different thresholds going all the way from 8 to 32 nanograms per ml. Now, when they grouped the studies at the threshold of 10, they found that choosing that threshold will significantly improve the live birth rate and significantly decrease the miscarriage rates. Now, when they used higher cutoffs, the difference was not that important. So they came up with the conclusion that maybe the threshold that we should be using should be around 10 nanograms per ml. They also looked at the ceiling effect. You know, what if the progesterone was too high? Is that harmful for your transfer? Well, again, the jury is still out when it comes to the ceiling effect. It seems that progesterone levels that are very high before the transfer, when we're talking about 50 nanograms per ml and higher, they might impact the implantation, but this requires further studies to be confirmed. So we have the threshold, what to do if your patient has a lower threshold than 10. Do we rescue the cycle or do we cancel it and start with another protocol? Now, the first studies published on the rescue protocols showed that they didn't show any improvement, all right? You look at these studies more than 5 years ago, showed that there wasn't any improvement when they rescued the cycle. But if you look at these studies, what they did is that they increased the vaginal progesterone, which obviously didn't help in increasing the progesterone level. Now, recent studies have been coming, and we have seen lots of them. This is one of the biggest and I think most comprehensive ones published last year. This is a prospective cohort study from Spain. What they did is, look here, they have more than 500 euploid blastocyst transfers. They measured the progesterone on the morning of the day before the transfer for all patients at the same time, and they put the cutoff at around 10.6. Now, when patients had a cutoff, had the progesterone level less than 10.6, they added an subcutaneous injection of 25 milligrams of Proitex. Now, here are the results. The first thing they saw that, look at the number, 40%, almost 40% of the patients had a progesterone level lower than 10. And this is something that we have seen quite often in these studies. Most of these studies that look at the cutoff, they report an average of 25, 30, even 40% of patients less than 10. Now, when they gave them the injection, you can see here, 98% came back to 10.6 on the day of the transfer. And as you can see for the results from the patient that were rescued with the subcutaneous progesterone had comparable live birth rates and miscarriage rates to the control patients who had the progesterone already higher than 10. So this is now something that is being widely used, measuring progesterone on the day before the transfer. And if that is lower than 10, then you add a subcutaneous injection, and you can measure the progesterone the second day, the day of the transfer, to confirm that you have a higher than 10 in order to proceed with your transfer. Moving on to natural cycle, to transfers and natural cycle. I think you've all noticed that there has been an increased interest in natural cycles recently. And this is a PubMed search that I did last week. If you just put the natural cycle frozen embryo transfer here in the search engine, you can see the number of publications per year. All right, so this is February, not even the second month of the year, and you already have more publications than what we had 10 years ago. So there is an increased interest in natural cycle transfers, and we'll see later why. So for natural cycles, it's very easy. You start with an ultrasound on the second or the third day of the cycle in order to rule out the presence of any cysts or corpus lutea. Now, some centers will measure the progesterone to see if it's higher than 1.5, but I'm not really aware of any studies that showed that this has any benefit on the cycle. You start monitoring with an ultrasound. Whenever you have a follicle of around 15 millimeters, you can start doing your measurements of estradiol, progesterone, and LH levels. You can do them every day or every other day. And whenever you detect your LH surge, you can schedule your transfer. Usually it's 4 days after the surge if it's a cleavage stage embryo, and it's 6 days after the surge if it's a blastocyst. Now, this may seem pretty straightforward, but there are many questions that are still to be answered. The first is, how do you define the LH surge, all right? So should you measure the serum or the urinary LH? Now, there's a trend towards using the serum because the urinary LH has some false negatives, and usually it comes later than the serum one. The second is, what is the cutoff point for an LH surge? Most studies will report using the 80% rise. So you're measuring your LH every day. Whenever you see an 80% rise that's sustained later on, this means that you have your LH surge. Some will use this association of an LH higher than 17, along with a drop, 30% drop in estradiol that is seen with the LH surge, while others would just simplify it by using an LH surge with an LH higher than 10. One thing you can do to help with defining your surge is measuring the progesterone, because as you all know, once it reaches higher level than 1.5, then you can say, yes, I have had my LH surge. And you can add the ultrasound monitoring. Some will use the appearance of the corpus luteum or the disappearance of the follicular collapse as a sign of the LH surge. You know, all these, there isn't really a standard practice, and all these will lead to difference in the day where you transfer your embryos, which might lead to the differences in the outcomes that we're seeing in the studies reporting on true natural cycles. Another big question in natural cycle, do you need luteal phase support? Now, I found 2 old RCTs dating back to about 10 years ago that looked at that. The first one, this one that looked at using vaginal progesterone the day before the transfer in natural cycles compared to no luteal phase support. They found an increase in the live birth rate when they used the vaginal progesterone. The other RCT used HCG in the luteal phase, and they didn't report any improvement in the live birth rates. Now, this is an interesting study that I found from a couple of years ago coming from Spain. This is a retrospective study, all right, an observational one. What they did is they looked at the natural cycle, almost 300 transfers, and they looked at the progesterone that was measured the day before the embryo transfer. And again, they used the cutoff of 10 to define patients with a lower than 10 or higher than 10 progesterone. Again, you look at the number, 37% had less than 10. So this is the same as what we see in the artificial cycles. And they found that the live birth rate were significantly lower in those patients because they had a lower progesterone. So I think this is quite interesting. Maybe we should start measuring systematically, if we're doing a natural cycle, start measuring the progesterone on the eve of the transfer. And if that is low, then we can add progesterone. And I believe we'll be seeing lots of studies in the coming years about this protocol. The modified natural cycle, obviously it's the same as the natural cycle. However, here, whenever we have a leading follicle that's above 16 millimeter, we're gonna trigger with an HCG. And the transfer will be performed 5 days later if it's a cleavage stage, and 7 days later if it's a blastocyst. Now, there are some controversies when it comes to the modified natural cycle. The first is, what about the LH surge? Because when you're doing a modified natural cycle, you might want to look for the LH surge because it might come before your injection. So what to do in that case? Should you change the transfer to a day earlier, or should you keep it? There's lots of studies on the subject, different results, but the common practice is if you detect an LH surge, probably it's better to do your embryo transfer a day earlier. And the second question is, should you add luteal phase support? Again, lots of heterogeneity. Theoretically, you don't need a luteal phase because you have your HCG and you have your corpus luteum. But if you look around the studies, you'll see that many will use some kind of luteal phase support. Now, this is a very interesting RCT that is actually being done right now. This is a Scandinavian RCT where they are comparing HCG, the transfer on HCG +5 or +7 or +6 for blastocyst with or without luteal phase support. I think when we have the results of this RCT, we will have more detailed answer about these two questions. Now, as we've seen, the modified natural cycle is a lot easier to perform than the natural cycle, the true one, because when you trigger your patient, you're going to know when they're going to do the transfer, and there is no need for the serial monitoring that we see with the true cycle. But many studies, early studies, had shown that when you trigger your ovulation, a natural cycle, you might be harming your chances of implantation. Now, there were two old RCTs, again, dating back to 2010. This was often cited by Fatimi and colleagues. They had shown that injecting HCG will lower the pregnancy rates. The other one did not show any changes in the outcomes. This is a recent one published 2 years ago, coming from Belgium again, where they compared natural cycle to modified natural cycle. There was no difference in the clinical pregnancy rate, but of course, the patients and the doctors preferred the modified natural cycle because there were fewer visits and fewer measurements to be made. Now, this is a network meta-analysis published last year. I'm going to get back to it later on. But again, when they compared the outcomes of a natural and modified natural, they didn't find any significant difference between the two. So it might be reasonable to think that by triggering our patients in these cycles, it will be easier for us, easier for them, and we will not be harming their chances. And last but not least, the mild ovarian stimulation protocol. This is quite standard. So you're going to be using clomiphene, letrozole, or low doses of gonadotropins to stimulate your cycle. And whenever you have the criteria, we trigger with HCG, and again, you transfer 5 days later for day 3 embryos and 7 days later for your blastocysts. The idea behind mild stimulation is that it might improve some subtle follicular and luteal phase defects that might be present in some patients. It might improve the endometrial milieu, the thickness even. And for older patients using exogenous HRT, it will lower the risk of thromboembolism. Again, clomiphene is probably less used than letrozole because of its negative impact on the endometrium. So the most commonly being used nowadays is letrozole and sometimes the gonadotropins. As for the luteal phase support, again, the rationale is that you wouldn't need them because you have your corpus lutea and you have your HCG. But again, most studies nowadays will use some sort of luteal phase support in these patients. So we've seen all these protocols. It's very difficult to compare them and make out which one the best because, as you've seen, there are so many variations in each and every protocol. Now, I chose this meta-analysis, as I mentioned earlier, because it's actually quite good meta-analysis. They looked at the data. First, they looked at the RCTs alone, 26 RCTs, to see which was the better protocol. Now, if you look here, you had lower results with the artificial cycle, even though it is the most commonly used. Now it was followed by the true natural, the modified natural, and they have the best outcomes when they used the stimulation protocol. Now you have to be careful over here because here we don't have as many studies as we have in the artificial and the natural cycle. But this is quite interesting. When they looked at the cohort studies, again, lots of cohort studies, once again, the artificial cycle seems to be doing maybe a bit less than the true natural and the modified natural. But there are lots of heterogeneity in these studies and lots of things that you could criticize. So the authors ended up with the conclusion that there is no consistent superiority of any endometrial preparation for frozen embryo transfer. The Cochrane review from last year that included 31 RCTs, so more than 5,000 women. You see the evidence was moderate to very low. Comparing the natural with the artificial, uncertain results, of course, less cycle cancellation than the natural cycle. When they compared the stimulated with the artificial, they saw significantly improved clinical pregnancy rates, especially with the letrozole. So the conclusion of the Cochrane was that even though HRT and natural cycle are most commonly used, maybe there is some room to using mild stimulation in certain patients. And this is my last slide, and I think it's a very important one. I don't have time to go through all these, but we're seeing more and more studies about the neonatal outcomes of frozen embryo transfers performed in artificial cycles. They assume to be an abnormal implantation and placentation, which is probably due to the absence of a corpus luteum, the corpus luteum that usually secretes relaxants, VEGF, and other vasoactive substances that are essential for a safe and efficient implantation. So what we're seeing now that many studies are showing that when you're using the HRT for a frozen transfer, we are having hypertensive disorders, significantly more cases, a significantly higher risk of premature rupture of membranes, of postpartum hemorrhage, of large for gestational age babies, leading to more cesarean sections. Again, lots of data coming from several cohort studies from several countries seem to be favoring going to the natural cycle for frozen embryos. And I believe this is very interesting. Fertility specialists, we don't always look at these because what we look at is the live birth rate and we look at the clinical pregnancy rate. But I believe this is something that's very important, and we need to take that into consideration whenever we're transferring our embryos. Thank you for your time.
Thank you, Dr. Hady, for your excellent presentations. As a matter of fact, all the presentations were excellent. Before we start the questions, we had a message from our friend, Dr. Khaldoun Khamaisi, president of the Jordanian Society of Fertility, who is notifying us about a Congress who's going to take place next month in Jordan, the International Conference of the Jordanian Society of Fertility and Genetics. It will take place on March 9 to 11 in Amman, Jordan. There are 20 speakers from Europe, America, and the Arab world, and Dr. Abitayeh and Dr. Marwan Halabi are speakers in the conference. So thank you, Dr. Khamaisi. And we are also delighted that Dr. Arif Al-Khalidi is also with us tonight. And we can start the questions. Any questions to our conference, to our speakers?
Toufic, there is a question for Dr. Hady from Dr. Rula Hamadi. What is the best dose and route of progesterone to be given? So Dr. Hamid, if you can clarify more the question, it's about which protocol?
Dr. Rula Hamadi.
It seems we lost control on the connection.
There is also another question from Dr. Hamadi to everyone. What about the low dose of methylprednisone? Does it improve receptivity, endometrial receptivity?
The controlled studies did not really show any benefit of cortisone in increasing the success rate.
Thank you.
It was used as an add-on just to increase the success rate when you give, like you give baby aspirin or you give other add-ons, and the studies did not show really any benefit.
Unless we have any immunologic problem. It's case by case.
What kind of immunologic?
Lupus,
connective tissue disorder.
Seems there is a delay in the voice. Anyway, for the immune studies, if you want to consider the antiphospholipid syndrome, this is what you mean?
Not necessarily. For example, if we have lupus or if we have any connective tissues or any problem, in antiphospholipid, I think it's better to use anticoagulation. But in some cases, it seems it can help if we have an autoimmune problem or autoimmune disease. Not usually in all cases. Classical routinely, but in some cases we can individualize the treatment and we can give this treatment.
So you are treating the disease, the autoimmune disease, which is the best treatment with corticosteroid. But the question, as I believe, think, whether to use prednisone or prednisolone for all cases, if this was the question.
I agree with you, Dr. Hannoun, not routinely. I agree with you.
Normally, the only benefit for corticoid in IVF when we have on endometrial biopsy a high level of natural killer. So only for these cases, corticoid can be useful for implantation. In the other case, no need. The only study that shows a superiority of prednisone when we have high level of natural killer in endometrial biopsies.
Which is not really tested in all cases.
No.
I mean, this might
only when we have an implantation failure,
repeated failure,
or
yes.
miscarriage, and we have a natural killer in high level, we can use corticosteroids and we can have a better results.
Okay, I had a question in my mind for Dr. Snaifer. And the slide, and I know about that slide. When we transfer histologically, you showed a slide in the talk when you put a bad quality embryo and we do not have the migration of the cells. So maybe the explanation is that we don't have the release of chemotactic factors from the bad embryo or poor embryo quality, and this is why we do not have a response from the endometrial lining. Because we know that implantation, we should have secretion of or release of factors from the growing embryo. We should have receptors at the endometrial lining, and if we have adequate, if you want, talk between the two, we will have the implantation. Now the question, if we don't have many embryos, we have one good quality embryo and maybe another one poor quality embryo. Would you transfer the two embryos, saying it might increase your success rate? Or do we think that if we transfer the poor quality embryo, it will decrease the success rate by affecting the endometrial lining in a negative way? What do you think? Anything?
The problem, we don't have study about 2 or 3 embryo, but logic, because all the study was done about 1 embryo. But I think I think it's when we put a good embryo, and if we have a biosensor positive toward this embryo, the other could have implantation, but the problem, it will lead after to a miscarriage. The problem, it's not to implant. The problem, did we go to a live birth after, or it will be a miscarriage? For example, I will have a two implantation, but after one of them will miscarriage, will abort, and the other will continue. I think it's
so
about the selectivity.
So you will transfer it. You will transfer the poor quality, or you discard it with the good one.
No, I will transfer. You know, I'm obliged in my center to transfer all the embryo, and because of that, because I don't have the capacity to discard. But I think when we add the other embryo, I think I have a more success rate. But I don't think the live births will increase. The implantation, for example, it increased, but the miscarriage will increase.
So what about the other speakers? George, Hady, what will you do? Dr. Layal?
Normally in our center, we transfer only 1 or maximum 2 embryos. This is our rules. So normally we choose the best embryos to transfer. We prefer single embryo transfer if we can. And I don't think if we transfer bad embryos, we improve the chances of implantation for the good embryos. So in our center, we don't have any problem to transfer only the good embryos that we think they will increase the chances of pregnancy. And I don't think there's a better chance of pregnancy to transfer many embryos, even if they are all good. We prefer to freeze. We can freeze in our center embryos and to have a single embryo transfers many times to improve really the chance of this woman with one retrieval than to transfer many embryos at the same time. This is our politic in our center.
George, the question was if we transfer with the good embryo, one bad embryo, did this bad embryo will implant? Or the good embryo will help?
The implantation, yes.
I think the advantage to transfer a bad embryo, there's no advantage for me. No, when they show me the embryo before the transfer, I don't accept to transfer bad embryos.
But George, we know that there are studies transferring a grade C or grade 3 quality embryos, and we had pregnancies and normal babies.
We can do this when we don't have any embryos than this. But when we have a good embryo...
No, this was my question.
If I have no embryos, I have a 40 years old woman, she has one embryo and it's grade 2, I will put it. It's not a problem here. But if I have 3 good embryos and 2 bad embryos, I will not transfer with every good embryo a bad embryo. I will not do this. It's not, just we can have multiple pregnancy, and it's not a good thing for a center for me. It's better to have a single pregnancy and with better results. Yeah, for me, if she is pregnant with twins, it's not a success, or with triplets.
But are you transferring, George,
because of this question, because you're talking about the twin pregnancy, I have a question for Dr. Hady about the frozen embryo. Do you think that we should, all of us, start to do the natural cycles or the modified natural cycles, and this as a medical legal responsibility, but because we know more and more now that the classic treatment, the replacement treatment that we are using is doing more complication in the obstetrical, on the obstetrical level?
Thank you, Layal. It's a very interesting question. I don't think we're there yet, because whenever you have studies about babies born from IVF, you have the risk of bias that comes with the IVF itself and the population. But as we've seen, the evidence is more and more significant. So I think, personally, I've always been a fan of modified natural cycle. But the problem is, there was, if you look a couple of years ago, people were saying that modified natural cycle is not as good as natural cycle. And we all know that in Lebanon, it's very difficult to do a natural cycle because you can't measure LH and progesterone every single day at the same lab at the same time. So I think modified natural cycle, with the studies I've seen when preparing this presentation, is a really very interesting alternative. Up until now, I've been using it only in patients who had tried HRT and did not succeed. But I think from now on, we're going to be switching to more and more modified natural cycles, especially given the prices of medication. When you're doing modified natural, you're just using one trigger, one HCG trigger, and probably will add the slightest dose of progesterone, probably Juvaston or even one vaginal progesterone. So I believe personally, I will be switching to modified natural cycle most frequently from now on.
Thank you.
We still have 2 questions from the audience. The first one is from Dr. Zainab Osman Haidar, who is asking, do you freeze an ovule for a single woman, 25 years old, who has an AMH of 1.2?
To whom addressed?
To you.
You see, you have to counsel your patients. And in egg freezing or social egg freezing, we are having young girls or young women unmarried, I mean, who are requesting egg freezing, and they have a low AMH, and it's a matter of counseling. I mean, you have to counsel that the aim of the egg freezing is to make sure, or not make sure, is to have the most probably a pregnancy later in the future when these eggs are needed. And we know that the success rate of having only one egg is really very low, because that egg might not fertilize, or if it fertilizes, it might not grow in a proper way, in a good manner. So despite this, we are having cases, patients coming at age 40 or 41 or 42, and despite counseling them about the success rate in the future, they say, I want to try, I know this, but having 2 or 3 eggs is maybe better than having none. And sometimes, after counseling them adequately, if they insist, you will go with them and you will do an egg freezing cycle. For young patients with 2 or 3 eggs, I would tell them that these 3 eggs maybe are better than 9 eggs or 10 eggs in elderly patients, because they might fertilize, you might get good embryos, and with a single good embryo transfer, we might have a pregnancy.
Dr. Hannoun, she is at 1.2 AMH. 1.2, it's not a catastrophe, huh?
1.2 is still considered as a normal, within normal. More than 1 is considered. No, I thought, they mentioned that if the patient, what I heard, if the patient gets only 1 egg, this is what I heard.
25 years old patient, and AMH is 1.2 singles.
1.2. Definitely you will do egg freezing cycle. Definitely. 25, definitely. But I will tell you something. The last thing I want to comment about it is that you have to counsel your patient that if she has to go into egg freezing, if she can afford to have multiple cycles with a low AMH, it's better for her, if she can afford financially. Okay?
Of course.
Okay.
I have some remarks. Can I, Dr. Toufic?
Go ahead, please.
This woman, this girl, 25, she wants to do only egg freezing because of the level of AMH. This was the indication?
We should ask Dr. Zainab. We don't know the patient.
Because I think 25, as Layal say, with 1.2, 1.5, we can't wait a little bit. Perhaps she will be married these 2 years. If she will pass 30, so we can go to do egg freezing. I don't think it's urgent to do.
I agree.
I agree too. Maybe
all
Dr.
of us agree.
In the next meeting, we will talk about social egg freezing and maybe the level of AMH, CFA, review de la littérature about all this. Maybe it's an interesting topic for the next meeting. So
we'll organize something for the next webinar about this.
Sure. So we would thank you, all of you, all the speakers, for the excellent presentation. Thank you, Dr. Abitayeh. If you want to add anything at the end, George.
Thank you
for my colleague Toufic. I forgot. Sorry, George. I forgot my colleague Toufic, my best friend Toufic.
Thank you.
Thanks.
I'm lucky. I'm really lucky.
Thank you for all of you. Thank you for the speakers, Dr. Hannoun, Dr. Snaifer, Dr. Hachem, for your excellent presentation. Thank you, Layal and Toufic, for the exceptional moderation. Big thanks for Merck because they are sponsoring our webinar. Big thanks also for Science Pro because without them we can do anything. We can't do anything without the technical support. And thank you for all the attendees with us. Our next webinar will be in March. I think it will be on the 15th of March. I will send you all the information and hope you enjoy our webinar. Really, the presentation was excellent this evening and the success was excellent because we were more than 290 attendees in this webinar. Thank you very much. Have a good night and stay safe.
Thank you, everybody.
Merci, George. Thank you,
Toufic.
Bye-bye.
Thank you, Dr. Hannoun. Thank you, everybody. Thank you.
Original, mature, still looking good and easy to use, and still having an impact.
I can feel totally confident when I prescribe Gonalev because I'm sure that I'm making the best choice and this is the best gift that I can give to my patients.
By potency, consistency, and safety.
And has transformed in many ways the way in which we carry out ovarian stimulation. It was the original recombinant FSH, and it emerged around about the same time as the antagonist. And together these two compounds have altered the efficacy and the safety of IVF in a very profound way.
I feel safe and I feel I'm doing the best to control the ovarian stimulation on my ART patients.
In my daily practice with Gonalev, I'm sure that I will maximize the oocyte health with a reduced amount of drug used and with a better compliance for my patients.
It is safety, consistency, reliability, and success.
I will never forget 25 years ago when I visited Serrano Laboratories in Boston and was introduced into the procedure of producing recombinant FSH, Gonalev, and became the gold standard in my center. Nowadays, also in addition with recombinant LH.
When we started this journey, we could have never imagined it would take us to where we are today. Looking back, it was during a time of pioneering advancements in biotechnology that Gonalev was born. It was possible thanks to a deep love for science and a lot of determination. Innovation has always been an integral part of our patient-centric journey, striving to contribute towards an optimal treatment experience. And so, Gonalev has changed and grown over time, responding to your needs and your patients' feedback. Over 4 million babies have been born worldwide, thanks to your efforts and the helping hand of Gonalev. It's been an incredible journey so far, and yet all this is only the beginning.
It says a lot that this product is still going strong 25 years later.
Thank you and congratulations for your 25 years of life. Let's go together for 25 more.
We have an exciting road ahead of us, so let's raise a toast to realizing millions of dreams yesterday, today, and tomorrow.
So I go, okay.
Ready? 1, 2, 3. We got not 5, 10.